The next speaker is Dr. Frank Mitros. Dr. Mitros is an emeritus professor of pathology at the University of Iowa. He's part of the Odorizio Howe Mitros type team, part of a multidisciplinary team out there. And he's going to talk about the role of pathology and its impact on net behavior. One reminder, questions come up to the front, and you can just sit it here on the desk, or you can turn them in at the registration desk and ask them to bring them into the room in the next few minutes. Dr. Mitros, thank you.
The weeds are starting to change in Iowa. They haven't quite gotten this far yet, but I thought I'd start with thinking about fall. I've been a pathologist at the University of Iowa since 1976, and I got into the neuroendocrine tumor area because since I started, was always interested in gastrointestinal pathology. And when Dr. Odorizio arrived, there was a sort of a natural fit. And with his arrival, I've seen many, many cases over the past almost decades now. I have nothing to disclose. My first slide is very unreadable. And it's perfectly so. If you look at it all, this is a very important paper that's come out. It's the minimal pathology data set. And Dr. Klimstra and a team, which I'll talk about a little bit, have assembled that and approaches it for the resections of the primary tumor, resections of metastases, and biopsies of the same. And in fact, all of those things that are mentioned here are things that as one goes through these cases, one needs to be aware of and think about. But I've tried to boil down what actually gets done into something that's a little bit more understandable and approachable, and give you a little bit more direct view of some of the important things that I think occur as a pathologist deals with some of these tumors. First and foremost, as we get a biopsy or resection, we have to make a diagnosis. And that includes giving it a name and saying where that came from, which is a combination of what we're told by the surgeon and what we see with our own eyes. And we also have to look and see if there's anything going on in the organ in which we get it that might make a difference in the way that this tumor may behave. And then very importantly, and this is something that is not done as often as it should be, is to assign a grade, meaning how active this tumor is, how aggressive it's likely to be, and a stage, and that is, what is it doing with relationship to the surrounding organs. And that's fairly basic to all tumors in pathology, but there are a lot of nuances that show up when you're dealing with these neuroendocrine tumors. What pathologists do is they name things in past and in sort of religious theological things. The idea of giving a name gave you power over it. And if you don't have the right name, you don't have that power. And then you try to classify what's going on. Now, one of the terms, obviously, that's very important and we are all very familiar with, and it's all around us, is carcinoid. But one of the problems is, has been pointed out by Dr. Warner, is this has led on the part of some physicians to misunderstanding, not understanding the true nature of these. So there is a lot of people that are involved now who are moving away from using the term carcinoid. That is such an entrenched term, I don't know whether that will ever happen, but I thought we should talk a little bit about the terminology, because I think that's important, because you'll see different things on the pathology report. Now, as a pathologist, we try to look at a tumor and decide whether it's benign or malignant. And with the neuroendocrine tumors, the carcinoids, these differ from other tumors, which usually, such as carcinoma of the colon, which usually manifest themselves quite rarely. You look at them and you see all sorts of changes in the cell nuclei and the way that they form structures, and you say, well, this clearly is so far from normal, it's got to be malignant. But the neuroendocrine tumors tend to be very insidious in that they look very bland. They look like a cell that would cause no harm in the majority of cases. And this is what's caused so much of the problem in the past. Also, when I first started, long before Dr. Odorizio arrived, when I was in my residency, we thought we could, if we looked at the tumor hard enough, find some magical way of saying this one is clearly benign and this one is malignant, and that we could apply these to tumors wherever they were. And that often is really not the case. Should all neuroendocrine tumors have their own system? Well, there's some evidence to support that possibility, that they behave differently depending on which organ they come from and what conditions there foster their formation. What this all amounts to, though, and I've seen an awful lot of this in the last 2 decades or less, there's been a rapid evolution of information and thought about these neoplasms, more so in the perspective that I have as a pathologist than has far more than has occurred in other tumor systems. And there will continue to be change. So whatever you hear today may have a little different outlook applied to it 5 years down the road, or maybe not even that long. So I'll give a little pathologist's quiz over here and ask you to look at these 4 pictures and tell me which one is malignant. They all look pretty much the same. Actually, I can remember when I first started studying pathology, it all looked the same to me when I was looking at the pathology textbooks that people had to teach me how to look at things. We're very visually oriented in pathology. We look for subtle clues in order to be able to categorize things and give, importantly, some prognostic information to our colleagues in internal medicine, oncology, and surgery. Now, if you look at this picture, you can't see the faces on those that writer very well. But if you look very carefully, you can start seeing that hidden in the background there are some very subtle clues. And if you look at that for a little bit, you start seeing some faces in there. And this is a lot of what is found in the interpretation of the slides for the various tumors that we see. Sometimes it takes changing your point of view. And that, I think, is one of the things that's been important with our understanding as physicians, as pathologists, about carcinoid, about neuroendocrine neoplasms, about neuroendocrine tumors. That is, they are tumors that you have to be very careful about because they're deceptive in their appearance, and some of the rules that apply to almost all the other tumors don't apply here. So, which one is malignant? Well, backing off a little bit now, so that we see at low power where they were, and that little blue dot is pretty much the size that you saw in that first photograph. As you back off, the bottom left corner was a neuroendocrine tumor, a carcinoid of the ileum that had metastasized to a lymph node, which is the panel above it, and the one to the right was a metastasis to the liver, whereas the panel that I first showed you was from an appendiceal lesion that measured 0.4 centimeters, and after the appendix was removed, and this was found incidentally, the patient was done with it, but they all looked like this. And that's part of the reason why there's been so much misunderstanding on the part of pathologists in particular about these tumors, because a pathologist who's used to looking at malignancies that arise in the colon would look at this and say, well, that looks very bland. I'm surprised that it's going to do anything. Now, the bottom line, I think, when it comes down to it, is that all neuroendocrine tumors are malignant. You can sort of modify that a little bit by saying the neuroendocrine tumors are potentially capable of exhibiting malignant behavior, and the behavior of some can be predicted with reasonable accuracy and can be considered to be biologically benign, like that appendiceal lesion. So if you know enough about the tumor, where it came from, under what circumstances, you can make reasonably accurate predictions. And unlike other tumor systems, it's not from just looking at that one microscopic field with standard H&E staining. Let's look a little bit at slides, and I know you're not a pathologist, but I think I can walk you through this, of a typical carcinoma, early carcinoma of the colon. Now, there's the carcinoma that's arising from an adenoma. The adenomas of the colon usually are present for up to 10 years before a cancer develops in them. And then the cancer will take off, and once it sort of breaks through that red line and gets into the layer underneath the very lining layer of the colon, it has access to get into the lymphatics and off to the liver, so we'll call it a carcinoma. But we know from experience at looking at these that if it's only in the submucosa and doesn't get down into that muscle layer further down, and if the lymph nodes are negative, that patient is very likely to be cured and will be free of disease 5 years later. we don't go back and change the diagnosis to a benign diagnosis in that instance. So, I think that the problem with the neuroendocrine tumors is that people don't realize that you have to have a very long period of time, and that many of these tumors, for example, the one in the appendix or some of the ones that you'll see in the stomach, if removed, may not recur. But that doesn't mean that they were necessarily benign. And I think taking a cautious approach and just making the assumption that all of these tumors have the potential for malignant behavior, regardless of where they arise, but that potential will vary tremendously depending on the size they are when they're found and what caused them in some circumstances to arise to begin with. The other thing which is interesting, I think, in comparing the two, carcinoma in the colon and, say, neuroendocrine tumors that arise in the colon and elsewhere, is that there's a very well-described precursor lesion that can be attacked in adenomas and the carcinomas of the colon that arise from them, whereas the same is not true, or at least has not been recognized in the majority of situations in which we deal with neuroendocrine tumors of the gastrointestinal tract and elsewhere. Now, as has been said a number of times, these neuroendocrine cells are scattered throughout the GI tract and elsewhere in the body as well, and they may produce a whole variety of hormones. In the old days, we used a silver stain. Nowadays, we'll use immunoperoxidase stains to recognize them. That top is one of the ones in the small intestine, as is the bottom one. Those nice red granules you see that are beneath the nucleus in that area encircled by blue are some of the peptides, including things like serotonin that they may make. What has become, I think, important in dealing with these is the utilization of immunohistochemistry. Although I will say that the problem insofar as pathology has not been recognized in neuroendocrine tumors. On our standard H&E slides, the average general pathologist will recognize it as a neuroendocrine tumor, as a carcinoid, but what they may not do is realize the impact of that diagnosis and may not be able to provide all the information that's needed to give the person who's going to care for that patient some clue as to whether the tumor is going to behave more aggressively or not. The classic ones that we use to determine a tumor is of neuroendocrine origin is naptophysin and chromogranin. And if that's done for the vast majority of these tumors, it's just confirmation. It doesn't make or break the diagnosis. It doesn't provide any further information. There are some situations where it is helpful, and I'll show those as I go through this. What has really arisen right now is staining for the idea of what the proliferative index is. And their terminology refers to the antigens in the way that they're approached, MIB1, P67. But I think that has taken primacy over the last 5 or 10 years or so as a stain that a pathologist should have in his or her armamentarium in dealing with these tumors. Now, this article from 1970, from the year 2000 by Mark Wick, who's a very distinguished pathologist in the American scene, took cognizance of this and said, yes, we have to recognize that they all have potential for malignant behavior. And so he started espousing a scheme. They would call them all neuroendocrine carcinomas. And I know even people in my institution still use this scheme. And there are problems with it. And even though Dr. Wick is a wonderful pathologist, I think it has caused some problems. And some of you may have seen this on your diagnoses if you've seen your pathology report. For example, one of the things that troubles me is in this system, he could take that 4-millimeter neuroendocrine tumor at the tip of the appendix, which is not going to cause any problems, and call it a neuroendocrine carcinoma, which will cause confusion because that term carcinoma elicits a very strong response on the part of the patient and the physicians caring for that patient. What I would refer to as sort of the European system actually started a few years earlier than that, and what that basically did was take cognizance of the fact that these tumors are individualized depending on where they arise, and that your ability to predict is importantly guided by that, as well as several other things such are listed here. And again, we have that proliferative activity as a very important one. And it is clear, as I've looked at these, is that a neuroendocrine tumor of the appendix is not the same as one of the stomach, is not the same as one of the stomach that arose in autoimmune gastritis, is not the same as one of the pancreas. They all have a few nuances that will make them behave a little bit differently. Now, there are neuroendocrine cells scattered about the body, and we're starting to become a little bit more aware of them and aware of some of their proliferations. The stomach is a key area, and for a couple of reasons, one of which is personal. I take particular interest in that, but I think it's important because it's a model that shows us how we can understand some of the pathophysiology and maybe intervene at an earlier stage. If you look at the stomach, circled in red there is the business end of the stomach, that distal portion of it just where it joins the duodenum. And there the cells lie, they're in little green dots over there that produce gastrin, which drives those cells in the proximal stomach, circled in blue, to produce acid. And there are also neuroendocrine cells there, ECL, endochromaffin-like cells, that are driven by the production of gastrin. And if you have a lot of gastrin for whatever reason, those neuroendocrine cells will proliferate. Now, the most common thing that will cause these cells to proliferate and raise your gastrin is pharmacologic. There are many people in this country and elsewhere that are taking proton pump inhibitors or H2 blockers because of problems with acidity, either ulcer disease or esophagitis. And since they interfere with the ability of those parietal cells to make acid, the gastrin cells get turned on. When they get turned on, the enterochromaffin cells, enterochromaffin-like cells in the stomach also get turned on. There are patients who have a disease which destroys parietal cells, autoimmune gastritis, that is the underlying disease that causes pernicious anemia. And once the parietal cells are gone, there's no acid, and so those gastrin cells, again, are very, very active. And a disease which has been mentioned and will be mentioned later today, the Zollinger-Ellison syndrome, in which the tumor itself produces gastrin. Now, here is a stomach from somebody with too much gastrin. The cells look sort of like fried eggs. If I were to look at a series of gastric biopsies from patients that were taken in the 1970s, I would see maybe in a field like this 2 or 3 of those cells. A field like this tells me this patient has a lot of gastrin, but it doesn't tell me why. The patient can have a lot of gastrin being produced, either because they are on proton pump inhibitors or because they don't make acid, as in pernicious anemia. You could stain them for gastrin, which helps you see the numbers, and that may help if you're trying to decide if they're increased or not. So the loss of parietal cells is a situation in which we do know a precursor lesion that causes neuroendocrine tumors to arise here in the stomach. And with no acid, achlorhydria, you get elevated gastrins, you get those ECL cells to hyperplasia, and there's sort of a sequence that you can see, and eventually a neuroendocrine tumor or a carcinoid will develop. An important concern is whether the acid-inhibiting drugs, proton pump inhibitors, will go all the way to neuroendocrine tumor. They commonly will cause hyperplasia, where I can see nodules through the microscope, but there have only been a few case reports thus far about these actually causing a tumor to arise in the stomach. There has been an increased incidence of gastric neuroendocrine tumors, more so than some of the others. Whether this is due to improved endoscopic techniques or whether the possibility that these drugs, especially in someone who otherwise would also have a predisposition to develop one of these tumors, is yet unknown. As you get to the small intestine, the colon, there are just numerous of these cells, and there is some subtle variation that I'll see in these cells just using standard techniques. Actually, just with light microscopy, not necessarily using chromogranin or synaptophasin. But there are not as clear a clinical condition that leads to hyperplasia. Here again we see our friendly neuroendocrine cell when it's normal and is important for the overall normal function of the gut. Sitting next to the Panette cell, which has bigger red granules up top, they're the ones that are important for digestion. They can be increased in certain situations with inflammation, most notably inflammatory bowel disease, Crohn's disease, and ulcerative colitis. And one of the things that I'll often see in those patients, who I also spend an awful lot of time looking at, are increased numbers of cells. You can see a lot of cells here with those little red granules. And those patients will occasionally develop small tumors that are neuroendocrine tumors as well. I think one of the important things that needs to be done yet and looked for are what the precursor lesions are for some of the more common neuroendocrine tumors. The vast majority of the ones that I see in the ileum, which is a very common site, obviously, do not have any clear-cut underlying predisposition. The battle of the alphabets, okay? And if you read any of the materials put forth by these very important and very august organizations, you may find significant differences in the way they approach things terminologically. Does that mean that one is right and the other is wrong? No, I think it reflects the fact that there's been an increased movement of late, and we're all trying to find out things which are important and which will sort out and be the most important ones for prediction over time. Now, as a pathologist, I'm particularly fond of this paper, which came out a couple of years ago in the pathology literature, in which this large group of individuals, and I'll give you a little bit more detail about them, got together and tried to deal with some of these differences and find out from a consensus what was going on. This Delphic consensus process means that these 20 physicians, all of whom have expertise, are asked a series of questions, and they go into some detail about how they push them they may come back on the question and rephrase it, but eventually they have to answer yes or no. And in order for this to have a consensus, you'd have to have 80% agreement. There were 12 pathologists. After all, this was developing that minimal pathology data set that I started off with, that huge slide. So they outnumber the 4 oncologists, 2 gastroenterologists, and 2 surgeons. But a pathologist who functions in a vacuum is not going to do the job right at all. So you have to have communication going back and forth between the various specialties. There are 108 questions, and the consensus was reached for the majority of them. No consensus was reached for 17 after innumerable attempts going back and forth to hone in on these questions. And some of it refers to terminology. Neoplasm preferable to tumor. And some of you would prefer that we always use the time-honored term of carcinoid. And there are problems whichever way you look with any of these. You have to, whoever writes a report has to be fairly consistent. People have to realize what they're trying to say with their report. Another important question they couldn't agree on are well-differentiated neuroendocrine tumors always low grade, or can some of them be high grade? Are immunohistochemical markers for general chromogranin synaptophysin mandated as necessary in all cases? And there was disagreement on that. From the pathology standpoint, and I'd be interested in how it broke down from the pathologist versus the other specialties, for the standard case, for the usual tumor arising in the midgut, in the stomach, in the rectum, and most of the ones arising in the lung, our experience with standard stained sections is sufficient. You can hone it or add some strength to it by doing this, but they're usually not necessary. I'll show you in a little bit one of the 2 situations in which I do think they are necessary. And then should a formal count, they don't disagree that a count or some effort should be made to give a proliferative index, be performed to get the key 67 labeling index. On the other hand, there was plenty of agreement, 84% of the questions. The term neuroendocrine carcinoma is reserved for poorly differentiated neuroendocrine neoplasms. And that gets away from that problem that I talked about that exists, and some of you may have seen, for using neuroendocrine carcinoma for the well-differentiated or intermediate differentiated, the grade 1 or grade 2. And importantly, they say some estimate of the proliferative capacity should appear in the report, either a mitotic count or an immunoperoxidase stains in MIB1P67 area. Another hand, there was plenty of agreement, 85% of the questions. The term neuroendocrine carcinoma is reserved for poorly differentiated neuroendocrine neoplasms. And that gets away from that problem that I talked about that exists, and some of you may have seen, for using neuroendocrine carcinoma for the well-differentiated or intermediate differentiated, the grade 1 or grade 2. And importantly, they say some estimate of the proliferative capacity should appear in the report, either a mitotic count or an immunoperoxidase stains in MIB1P67 area. Other observations of note is that there are differences between grade and differentiation, and this gets back to what I was talking about. As a pathologist, you look at these, and they often look very much alike. And is there a difference between them? Granted, when you get to the poorly differentiated ones, meaning they no longer look like any cell that you've seen before, they've lost their cytoplasm, their nuclei are big, there are mitoses all over, those are a different and separable group. It is starting to appear that some of the more innocuous tumors may have a surprisingly high proliferative rate, and that's why I think that proliferative rate is so important. People have gone back and forth between mitotic count and the MIB1, the proliferative rate, and I'm starting to believe that doing the immunoperoxidase for the estimation is more important. Another thing which I think is helpful, except for the stomach, which I showed you, where there's a precursor lesion, unlike the colon where there's a known precursor lesion, the adenoma, we don't have that same luxury with these tumors too, where you can identify something before it reaches a point where it's going to spread throughout the body. Now, what pretty much people have started to agree on is looking at the number of mitoses per 10 high-power fields, and usually want you to look at least 50 high-power fields, and that can be done fairly rapidly, but it's actually fairly hard to judge because mitoses can be not so readily recognizable. Or doing an immunoperoxidase stain and giving a percentage of the cells that are present. And in either of these, you try to take it from the area that is most active, and that should give the most useful information. This has led to a separation into low grade, intermediate grade, and high grade. If you look at some of the different organizations, again, the battle of the alphabet there, you can see that in the first two categories, which are, I think, the most important and the most common by far, depending on who you are paying attention to, it might be a atypical carcinoid tumor, a neuroendocrine tumor grade 2, or a neuroendocrine neoplasm grade 2. And that is sort of fine-tuning, but it's that bottom below the red line, when you get to high grade, where that word carcinoma comes in. And again, this, I think, is important, and we should be clear on it, but you will still see reports of the people who have been following Dr. Wick and others at calling these lower grade tumors neuroendocrine carcinomas, which I think is misleading. Now, these poorly differentiated ones, seen here, the small cell and large cell variants, which are most common in lung but can occur elsewhere, to a pathologist's eyes at least, look radically different from the kinds of things that I've shown you. And they look far enough away from the usual neuroendocrine that this is one circumstance where doing the chromogranin and synaptophysin is, I think, an important step. Because a poorly differentiated tumor is just that. It doesn't resemble anything closely enough. It doesn't make glands. It doesn't make keratin like the squamous of the skin will do. But many of them will still be positive for one or more of the neuroendocrine markers, but it is important really only when you're dealing with the poorly differentiated ones. The chromogranin and synaptophysin, you pretty much have an idea what's going to happen in the grade 1 and grade 2. The question here, and again, to your eyes, I would hope, and to my pathologist's eyes, that grade 1 and grade 2 on the top, two bottom ones are the grade 3, they look very much alike. So the question is, how do you separate those? And this is where I think the proliferative index is so important. I think, if nothing else, if there's no, one take-home point, I've become more and more convinced as I've spent time working on these that this is probably the most important of the things that we can do as a pathologist. The stain will stain nuclei some shade of brown if the cell is anywhere in the cell cycle of proliferation. One of the things that's better about this is if you're counting mitotic rate, the portion of the cell cycle where the cell shows mitoses where you can actually see them through the microscope is a very small portion of it. So we'll have a lot more cells that are positive, and I think that gives you a chance for better accuracy and better prediction if you do the staining for the MIB1 P67. In that same paper of by Dr. Klimstra, he shows some examples of this over here and picks for the photograph that he included in the paper, two slides that are very near the cutoff point, one at 1.4% and one at 21.5%. If you recall, cutoff points tend to be at 2% and 20% in most studies. Although there is concern that that might not be the perfect cutoff point, where we're still working on a lot of these things. What is clear, though, is some knowledge. Is there a little bit? Is there an intermediate? Or is there a lot of proliferation? That is important, and I don't think anyone disagrees on that. One of the questions that comes up is, can the tumor be well differentiated but high grade? And I think as we do more and more of proliferative indices on more and more tumors, we're likely to find some. I've seen certainly tumors that I would have not recognized as grade 1 or grade 2 using a proliferative index until I used the proliferative index. On my standard microscope, they looked exactly the same, and lo and behold, one of them will have almost no activity, and the other one is at 4 or 5 or 7%. So, I think this is value added, and that's why it's important. I think where we're most likely to see this is going to be in the ileum, where some of those tumors which look bland can be more aggressive. So, grade versus differentiation. Differentiation, basically, to reiterate what I've sort of been trying to say in the last few slides, how closely does this reflect a normal, bland-looking cell? Whereas the grade now, more and more importantly, is honing in on what is the ability of this cell, or how fast is this cell proliferating. And we have to be ready for some dysynchrony between these two. And I'm thinking that, for the most part, it's going to be true that the proliferative index is going to prove to be very important. So how do you count it? That alone is a problem. Looking at this slide, what percentage of the cells have brown nuclei? And this is part of what I have to do on these. You also have to be careful because sometimes lymphocytes are present, are commonly present, and they can stain brown as well, so you have to distinguish those. That's a pathologist problem. I won't get into that. But assuming that all the brown ones are positive, how do you count that? Well, I started going blind, looking back and forth, or stir crazy or something, trying to keep track, and somebody would come in, the phone would ring, my beeper would go off, and I was up to cell 723, my goodness. And I felt something had to be done. So I hope you can see that. There are little circles that cut these into islands of about 70 cells each. And then I can write on the paper. What I do is, when I'm going to do this now, is I photograph it, bring these home with me. My wife can tell you, she sees me sitting there of an evening on these when I'm doing them. Because if I'm working at a scope with 5 other people, and I stop to take 10 or 15 or 20 minutes to do a count, they're going to go bonkers. They've got a lot of things they have to do too. So that's what I do on these. And as you look at it, that was 1.16%. That's a good fellow. You want that one. Here's another one. Is this going to be 2% or less, 2 to 20%, or over 20%? So I drew the little islands, and then I circled, and I put little dots now often as I've gotten more and more to using this estimate. It's not perfect, but it's a pretty doggone good estimate as to the number of nuclei, and somebody can come back and look at it and disagree with me if they want to. I circled the nuclei that I thought were brown, and then I counted all the cells that I thought were the neuroendocrine tumor cells that were not staining, and that one is 4.34%. Okay, so how should it be measured? Counting mitotic figures is, many still espouse that, and that is important, that's helpful. I tend to think that the immunoperoxidase stain is better. Some people say both. I'm not sure, since they both are laborious, whether you really need to do that. Do you estimate? Do you actually count the cells? How many? From what area? Can you use image analysis and put these into a computer? All of those are questions which are undergoing evaluation now. Now, going back to, regardless of the way in which you do it, mitoses can be hard to recognize for anyone, and I've done a lot of mitotic counting in other tumor areas, and I'm not convinced that they are always accurate. There are other tumors in which they are important. The difference in field size between microscopes, the difference in the experience of the pathologists, for the immunoperoxidase variability in staining, is it a light brown or dark brown, depending on where in replication it is. What really confuses the computer are some of those cells like the lymphocytes that are present that are mitotically active and can stain brown, which I think a pathologist looking at them directly has a better chance at recognizing. So there are a lot of questions, and people can get totally hung up on this, but I think the estimate in some fashion, and I think the way I estimate it, is pretty honest and gives you a pretty good look at it. What did this group of experts come up with? From a practical standpoint, providing an eyeballed estimate of the latent percentage was agreed to be the only method that could be strongly advocated at present. Yeah, but how do you eyeball it? And this is my eyeball right now. I think doesn't sound as drastic as you might think, because many of the cases, you look at it and there's no activity at all, and you know it's well under 2%. And those poorly differentiated ones where you know that they're bad, you often, I mean, they're way over 20%. It's at those cut points that are important. And the other thing, which is important, I'll come to in a second here, the cut points differ from one system to the other, and in fact, definitive clinical data to determine the optimal cut point do not exist. Some studies suggest that the cut points may differ between organ systems. So it is recommended to specify the actual proliferative rate in the pathology report in addition to deciding a grade based on a system that you reference, so they know what you're talking about. If you want to use the Wick system and call it a neuroendocrine carcinoma, I guess you can, but you should tell people that you're doing this. I've been trying to collect some of these now, and I'm hoping to get enough of these that I can share it with my colleagues, that they have several of these that are at cut points, and maybe have 3 or 4 that are just below and just above 2, and likewise with the 20%. And that'll make life a lot easier. But that's also quite laborious. Well, as I mentioned, my background is in the gastrointestinal tract, and so let's take a little look at these and how they do behave differently. And we'll give you some cases. This is a 32-year-old man with mild dyspepsia and had a nodule noted when they looked in his stomach. Everything else looked unremarkable. They did an endoscopic mucosal resection. There's a little bit of black at the bottom of the specimen here. They were able to go in with an endoscope and lift the whole thing out. We looked at this, and by gosh, it's our neuroendocrine tumor. Back to those slides again. It could be from anywhere. Once I'm down to this power, looks pretty good, but it's a neuroendocrine tumor. It was chromogranin and synaptophysin positive. Well, what's off to the side there? To my pathologist's eyes, those are those parietal cells that make acid. The fact that they're there means he doesn't have autoimmune gastritis. So this patient doesn't have pernicious anemia, and they don't look like they're increased in numbers, and they don't have another finding that I've seen in patients with Zollinger Ellison syndrome. So I could, in looking at this, say that this is a sporadic neuroendocrine tumor, not arising from pernicious anemia, not arising from Zollinger Ellison syndrome. Now, the pathologist could sign it out as this, and that is an accurate diagnosis, but not quite complete. And when you could see me in my earlier years making diagnoses there, and one of the things I said, if you made me look at all the diagnoses I made in the 70s, it would kill me, because I would disagree with some of them, and worse yet, if I didn't, I'd feel like I hadn't learned anything. So be kind when you see differences in terminology, and realize that it's a moving process, and that people can go back and review things too in the light of new information. Best, I think, the stomach is understood in terms of the pathophysiology, and there are really 3 separate types. The one that arises in pernicious anemia, which tends to be indolent. The one in Zollinger Ellison, in which there's a tumor elsewhere making gastrin, which sometimes is aggressive, and those that arise sporadically, like the one I just showed you, which tends to be very aggressive. And if you have mixed tumors, which we're not really going to talk about today, you might even get a 4th one. But a report from the 70s or 80s or 90s would have probably just said gastric carcinoid. Pathologist is going to recognize it as a neuroendocrine tumor. Carcinoid is standard terminology over the years. It's just now changing a little bit. And there's nothing wrong with that diagnosis, except I think a lot more could be said. Here's that sequence that I was talking about, in which there is increasing amounts of hyperplasia of these cells, which eventually become fused and over time can then form a neuroendocrine tumor. The time frame on that no one is quite aware of. If you stain with chromogranin, you can see there's an awful lot of ECL cells. There should never be more than about 1 or 2 cells scattered about in each of these glands, and here they're just along the side. That's one of the earlier stages. We see this all the time with proton pump inhibitors. It's part and parcel of pernicious anemia. The next stage are these little rounded clusters of neuroendocrine tumors, which are going to start to fuse and make these guys. That one is of particular interest to me because it's me. I have pernicious anemia, and I'm working on making a neuroendocrine tumor. I keep to be quite friendly with my endoscopy buddies in GI, and I'm hoping they'll pluck it out. And luckily, I'm in the indolent stage. If tumors go on, they eventually will produce visible nodules like this, and often patients with pernicious anemia may have 15 or 20 such nodules. So they are often multiple in the stomach as well. Zollinger Ellison syndrome, here the stomach has these big folds, rugal folds. They're big because they have a lot of those parietal cells that are making acid, since there is a tumor elsewhere producing gastrin, making the stomach make these. And if you look here, again to my pathologist eyes, these cells that are lining the glands have these big dilated spaces in them because they're being driven very strongly by gastrin, and that's what a stomach in Zollinger Ellison adjacent to a tumor would look like, and they wouldn't have any of those gastrin cells in the antrum, those fried eggs I showed you, because the gastrin is being made elsewhere. Now, staging is important in all of these, and the staging systems will vary a little bit depending on which of the alphabet groups you look at, but they all relate to how this tumor is growing in relationship to the surrounding structures that a pathologist will recognize. And I've seen enough circumstances over the years where people have argued about these as these systems change that I feel that what we should really do is get the information somewhere in the report so that if the system changes, the new system can be applied. You can apply a TNM if you want to get your staging, but then you should determine which one that you're using. So here's our old diagnosis, which I said was accurate, but could have been a lot better. And if you were signing that now, you'd say a neuroendocrine tumor, grade 1, the mid 1 was under 2%, measured 1.2, invades into the submucosa, that's for your staging, 1% of tumor nuclei, normal parietal cells, so you know it's not Zollinger Ellison or pernicious anemia. Much more complete, providing useful prognostic information. By the way, the gastrinomas in Zollinger Ellison can occur in duodenum, pancreas, and occasionally in the stomach. There are even some that were thought to be primary in lymph node, but I don't believe that. Here's a case from our institution in which this is a duodenum, and if I juice it up and stain it so you can see the neuroendocrine tumor, there's the gastrinoma. They can be mighty small. As a matter of fact, the biopsy I had on this one came to me where they said the patient has Zollinger Ellison. There's a tiny lump here, rule out a gastrinoma, and the first cut that we took didn't show anything. But I had this index of suspicion from my friends in gastroenterology, and we cut multiple levels, and we eventually found this small tumor hiding in the tissue that they gave us. It's not like a carcinoma of the colon, which is huge, and you see it right off. Some of these, especially the gastrinomas, but also some of the ileal ones, can be mighty small. I'm going to go very quickly over this one. It's a patient with neurofibromatosis who had a neuroendocrine tumor in the ampulla of Vater, which can cause obstruction. The reason I included this one, though, is if you look at this one, it looks very peculiar. It has some gland-like structures to it, to a pathologist's eyes, and there's this blue thing, which is a psammoma body, which is a calcification. That shape and the psammoma body typically occur in adenocarcinomas, and this could fool you. This is the one scenario where a chromogranin and synaptophysin in a well-differentiated tumor would be important. And the index of suspicion would be that you know that these tumors that arise in the area of the ampulla, the neuroendocrine tumors, can mimic an adenocarcinoma. So there was our stain on that one. The third case was a person with vague abdominal pain, developed some cramping. On colonoscopy, there was a tumor in the distal ileum. It was biopsied, it was a neuroendocrine tumor, and the ileum was resected. And you can see multiple tumors, even from the surface they look somewhat yellow, as is typical of neuroendocrine tumors. Ileal tumors are ones that often are multiple, 30%, 40%, depending on who you read. They have a very characteristic, I mean, I don't even need a microscope in looking at that specimen and then I cut into it and see the way that tumor has that slight yellow color and the way it makes the bowel into a knuckle, because as the tumor goes through the muscle, it elicits fibrosis. That started the cramping, the intermittent obstruction the patient had. I can confirm it with a microscope, and sure enough, it's our same old tumor again. Looks pretty good, and yet this one, compared to the one I showed you in the stomach, is much more likely to go on to nodes, liver, and really cause this patient serious difficulties. So they are peculiar. One of the interesting things, despite that multiplicity, I don't see a precursor lesion the way I do in the stomach, where the other situation where there are multiple neuroendocrine tumors that are common. Again, going through these, there are books that we keep in the pathology area, and my take-home point on these is not so much memorizing TNM systems, but making sure that you precisely describe, as a pathologist, how far the tumor goes with relationship to the surrounding structures. This is a paper that came out, and Dr. Rowland is going to speak later today. And the interesting thing here is he looked at the grading using the MIB1 and also looking at the mitotic index on the bottom. And note that he has a lot more tumors in grade 2 when you use the MIB1. And that can be important. If you look at this graph to the other side of it, the way that shuts down, there can be a lot of tumors with a relatively low mitotic index who have a higher proliferative index. And so I think these are some things that make me believe that the MIB1 is more important. Also, if you look at this grading and look at progression-free versus disease progression, the P67 proliferative index seems to be an excellent predictor, especially in some of the patients who don't have as aggressive-looking tumors. And when you look overall at what the best, some of the best predictors were, I think the P67 really stands out there as an excellent predictor. This is just that appendectomy which I showed you before. We're getting towards the end now, and those tumors should never be called, in my opinion, a neuroendocrine carcinoma. The other problem with these is measurement, and this is where we became aware of how important measurements were. Measuring is very difficult, depending on how that tumor appears in the appendix. When it's a small round glob, you're fine, but if it wraps around like this, people can get quite different measurements. I won't show you much about the small neuroendocrine tumor of the rectum, lest I fall through the floor. Again, it looks the same. If these are small and removed, they're usually in pretty good shape. So we'll finish with that, and a little later when we sit in the panel, we can have a chance for some questions as well.